So a very good afternoon to everyone here. So my paper is on utility of plus 1.5 diopter lenses, a test to identify the clinically significant hyperopia in routine school screening programs. So I don't have any financial disclosures.
Not moving. Slides not moving.
So we know uncorrected refractive errors are the most common cause of avoidable visual impairment, and hyperopia considerably gets lesser attention than myopia, and that is because we think it is almost entirely due to genetic or hereditary factors. It can produce reduction in both distance and near visual acuity depending on the patient's accommodative ability. However, there is a lack of data regarding the prevalence, the test, and the amount of hyperopia that requires spectacle prescription. So our main objective of the study was to investigate the utility of these 1.5 diopter lenses to test, identify the clinically significant hyperopes in school-going children. And the secondary objective was to study regarding the symptomatology presented by these hyperopic children. So it was a retrospective cross-sectional study using the REACH model. It was done for 3 years, and the study population was 285,177 students, included between the age group of 6 to 18 years. And the rationale of using these lenses is that we know fogging is a technique of inhibiting accommodation with plus lenses, and vision is blurred by creating an artificial myopia, making accommodation worse. So in hyperopes, accommodation is necessary to produce a focused image at distance and near. Vision will improve with the plus lens in patients with hyperopes, and an increase in accommodation may serve to compensate at least partially 1.5 diopters, which is known as the latent hyperopia. Hence, these lenses were used as a screening tool. We chose a cutoff of 1.5 diopters since clinically significant hyperopia appears after this value, which requires spectacle prescription. So coming to the methodology, so primary vision screening was done by using illuminated pocket vision screeners at 3 meters distance. Visual acuity cutoff was taken as logMAR 0.2 or 6 by 9.5. Now those students who read logMAR 0.2 were subjected to this 1.5 diopter test, and those students who did not read logMAR 0.2 in the preliminary examination were referred for direct evaluation directly. So then when they were subjected to this 1.5 diopter test, now the students who read the logMAR 0.2 with these lenses were referred for detailed evaluation to rule out clinically significant hyperopia, and those students who did not read with logMAR 0.2 with plus 1.5 diopter lenses were considered normal, and however they were inquired regarding the asthenopic symptoms, examined to look for any abnormalities such as squinting, nystagmus, amblyopia. If any such were found, again they were referred for the detailed evaluation. After that, subject to cycloplegic refraction, anterior posterior segment evaluation, and best glasses were given according to the prescribing guidelines based on the American Optometry Association. So coming to the results, a total of 287,155 students from 1,026 schools. 50% were males and 50% were females. 44% belong to the rural population and 57% belong to the urban population. The total number of hyperopes were found to be 1,379, just 0.5%. Majority of them belong to the 9 to 15 age group, and low hyperopia was the most common. So looking at this graph, the hyperopes were predominantly picked up from the preliminary examination itself, and 255 students from the 1.5 diopter test and 117 from the symptomatology group. And coming to the ocular symptoms, the eye pain and headache were the most common symptoms, and a total of 117 students, that is 8.5%, were identified from symptoms and eye abnormalities. So coming to the conclusion, the prevalence of hyperopia itself is extremely low, that is 0.5%, and hyperopes are predominantly picked up in the preliminary examination itself, and very few due to the 1.5 diopter test. And 1.5 diopter test is an additional step which will be very time consuming, expensive, when screening such large number of students. Hence, it is not a required test in a routine school screening program. Coming to the strength, we had a large sample size. It was 287,155 students, and a lower threshold of 1.5 diopters was taken as a cutoff for identifying hyperopia. Deletion of this step would mean time saving and lesser expenses. Emphasis may be given to other refractive errors which are very more common in the school-going age, and this model replicates the environment usually experienced by children, giving realistic assessment of vision. So limitations of the studies, our study population was aged between 5 to 15 years of age, and children below 5 years were not screened, whom hyperopia is more common. And few studies have compared 1.5 and +2 for lenses for ruling out clinically significant hyperopia, and concluded +2 as a better test to identify hyperopia. These are my references. Thank you.
So did you see any difference in the rural and the urban population where the hyperopia is concerned in the children?
Yes, ma'am.
In this
So it
age
was,
group?
yes, ma'am. It was more in the rural population than the urban population.
Oh,
Yes, that was,
yeah.
it came surprising to us as well when we carried out the study, ma'am.
Yeah, okay.
Have you seen a cardboard type of refractometer produced by LVP, costing less than 200, 300 rupees?
Yes, it came on in one of the
Yes, I'm
they
using
had a
that.
competition,
I'm using
yeah,
that.
and
Very simple cardboard,
cardboard.
and you they given a object. You just focus. That will give you approximate number how much myopia or hypermetropia she is
For
having.
screening.
That
we can-
seems to be a little
But
better. than
the
this.
question would be of hyperopia, you know, because
yes, exactly. The
to
hyperopia is
yeah,
also-
to
also
uncover
different.
it, you just need something to fog.
Yes,
Yeah,
yeah.
yeah.
That is the
Yeah.
basis
Yeah.
of the study. Very good.